Hello, everybody. Welcome to our Thursday webinar series. My name is Lourdes, and I'm happy that you are here with us today. Our topic today is on common blood work needed prior to treatment. And as always, I want to remind everyone to enter any questions you might have into the Q&A or the chat. Please make sure you do not ask specific questions of your case, but try to make them as general as possible. And I'm happy to introduce Jenna O'Rourke. She is a board-certified nurse practitioner specializing in gastrointestinal medical oncology at Beth Israel Deaconess Medical Center in Boston. She first started her oncology career as a bedside nurse taking care of surgical oncology patients and has now been caring for patients as a nurse practitioner for nearly 5 years. She thoroughly enjoys getting to know her patients and their families while helping them navigate some of the most challenging moments in their lives. Thanks for being here, Jenna.
Thanks so much, Lourdes. Hi, everyone. So today we're going to talk about a lot of blood tests, and essentially we're going to just learn about the most common blood tests that are checked prior to chemotherapy and immunotherapy. As you may or may not know, we often, as healthcare providers, will check blood work before each dose of chemotherapy or immunotherapy. And so we're going to kind of go through what's the most important things that are tested, why there's abnormalities, if those abnormalities are considered expected versus maybe need an intervention. We'll also go through things that would be normal. I won't be really giving like the normal ranges for each particular blood test because we'd be here all day and we have a lot of ground to cover in this webinar. So I'm going to kind of leave it more broad, but we're going to definitely cover a lot here. So first things first, I wanted to share this figure with you, which shows where our blood cells are produced. And so this is a photo of a bone, one of the large bones in our body. In the inside this, you see the yellow substance. This is bone marrow. The bone marrow is the location in which our blood cells are going to be formed. And so blood cells, um, in they start off as kind of immature cells where they don't have a specific destination per se. As they grow and develop, they can become mature into different types of cells. The three types of cells that we're going to talk about would be red blood cells, white blood cells, and platelets. Components of blood. So it's important to know that blood is composed of plasma, as you can see in this picture. Plasma contains a variety of substances such as water, proteins, nutrients, some wastes that will get excreted through the body, gases, and different molecules that help our body balance or stay in balance, rather. And it also contains red blood cells and white blood cells and platelets, which are those components that we just talked about. And so when a phlebotomist or a nurse takes your blood, um, you know, you just get a red sample and then it gets sent off to the lab in which there's a bunch of um, machines that will kind of be able to break down these components so that we can get values and numbers on the computer. And so we're able to identify how many white blood cells might be in a particular blood sample, how many platelets, how many red blood cells, and also take a look at things like electrolytes, liver tests, and a variety of other tests. So there's some abbreviations in which we'll go through. CBC, you may have heard, is what would be referred to as complete blood count. In a CBC, we'd be checking a WBC or white blood cell, RBC or red blood cell. HGB is hemoglobin. HCT is hematocrit. PLT would be platelets. If we break down the white blood cell count, we can look at what we call an ANC, which is particularly important for cancer therapy and safety labs in terms of starting treatment. ANC is absolute neutrophil count. I'm going to go into exactly what these mean. These are just the abbreviations. MCV and MCHC, these two are help in RDW, are helpful for evaluating anemias and specific iron deficiency anemia. Now we're going to move into our either CMP, Comprehensive Metabolic Panel, or BMP, Basic Metabolic Panel. So oftentimes the basic metabolic panel will be made up of certain electrolytes, the sodium, the abbreviation for that is Na, the potassium, K, the blood urea nitrogen, which is helpful in assessing hydration status, that's BUN, the creatinine, which is helpful to assess the function of the kidneys, chloride, an ion that we measure helps with balancing acids or bases and just kind of balancing the body, we'll say. Glucose, which is a marker of your blood sugar. And the comprehensive metabolic panel, the CMP, includes also the liver tests, which are on the next page. We can also evaluate calcium and magnesium. So you may see your provider write these things in their note. In particular, I've reviewed labs prior to treatment. K is low, will replete. So that means that the person's blood work showed that the potassium in the blood is low. Potassium is an electrolyte in the blood. And so repleting that sample would be to give potassium either through the IV or port or by mouth. Like I said, the comprehensive metabolic panel also includes the liver function tests. We have enzymes in the liver, such as the AST, the ALT, the ALK phos. And these are helpful for measuring the function of the liver, or rather, more so like the dysfunction of the liver, which we'll talk about soon. We see a lot and we hear a lot about the T-bili or total bilirubin, and also albumin, which is a helpful liver test. We'll talk about that too. Some other tests that might be checked prior to treatment, in particular immunotherapy treatment, could be thyroid tests like the TSH or thyroid stimulating hormone and the free T4, which is a hormone thyroxine. We also talk about tumor markers a lot, and so we'll talk about this as well. The most common tumor markers that we check in cholangiocarcinoma are CA19-9 and CEA, which you may have heard about. So to kind of move into some terminology, as a medical professional, we will kind of group results into normal, abnormal, and then critical. So within normal limits, each blood test is going to have a kind of appropriate range. They are all relatively similar from lab to lab. However, there are slight differences. For example, a potassium checked at, my hospital, the normal range might be 3.5 to 5.5, but the potassium checked at your oncologist office might be 3.4 to 5.5. And so each lab may have slight differences. However, all of the normal value ranges are generally the same. Abnormal results would be anything above the upper limit of normal or below the lower limit of normal. So we'll use potassium as that example. And I think I actually have that example on the next page. So essentially, if you're above that top number, like 5.5, that would be an abnormal result. If you're below the 3.5, then that would also be considered abnormal. Abnormal results can be expected given particular circumstance or medical condition. Um, as we're going to talk about today, chemotherapy is going to cause a lot of abnormalities, right? You're going to go into your patient portal or your MyChart or whatever EMR you use, and you're going to see a lot of red, and you're going to see things that are, the little caret up, the little caret down, indicating that things are abnormally high or abnormally low. Some of the results that we see on your blood work are going to be expected, and we're going to kind of go through that as well. Expected results from treatment do not always require action. Sometimes they do, and we'll review that as well in terms of what we can do to improve abnormal results with supportive therapies. Critical results are lab values that are so far above the normal range that a person may be at risk of significant harm or injury. And so often critical results require intervention. As an example here, we talk about the potassium within normal limits, 3.55, abnormally high, 5.1, but critical would be 6 and above. And so we would need to intervene on that. We would need to probably take an EKG. We would definitely replete the potassium in a controlled manner, because potassium fluctuations can have abnormal effects on the heart. And so we do things to reduce the risk of those complications. A point about labs. So we want to weigh change proportionately. So a change in a few points might have little clinical significance if the normal value is in the hundreds. So an example would be a low sodium of 132. The normal range for sodium would be 135 to 145. Well, this doesn't mean too much if the patient is asymptomatic because they're not too far off from normal. This 132 value would be an abnormal result, but it wouldn't require drastic intervention, likely. Every scenario is different, but likely wouldn't require drastic intervention. However, if we look at somebody's absolute neutrophil count, which is that a part of the white blood cell, we're going to go through all of these in more detail. This is just kind of an example of how numbers and decimal points matter. The absolute neutrophil count is a value less, it can be less than 1 in this particular example. So a value of 0.7 versus 0.5 could mean make a difference clinically, whether the person needs to be admitted, whether the person needs antibiotics, whether the person needs treatment change or hold or break. So just to give you an example about how, we have to think about labs in relation to their normal values, but yes. And so to move on here, we are going to now dive in a little bit more in depth about the CBC. And if you recall, the CBC is the complete blood count. So the first test on the complete blood count will be the WBC, or white blood cells. So there are different types of white blood cells. In terms of chemotherapy and immunotherapy treatment, the neutrophils are going to be our most clinically significant type of white blood cell that we're going to monitor. So neutrophils, you can imagine these as the little infection fighting soldiers in your bloodstream that are going to protect you from an infection. If you get a cut, bacteria is able to enter the bloodstream. When bacteria enters the bloodstream, the neutrophils are the first responders. They're going to rush to the site of the infection or the bacteria, and they're going to attack the bacteria. They're going to suppress the bacteria, and they're going to make them go away, make that bacteria go away. That's to reduce the person's risk of infection. Eosinophils are known for their role in allergy or allergic reaction. Um, the eosinophils often do not have any implications on treatment in terms of like if we see a mildly low eosinophil count, are we going to hold treatment? No. Um, the neutrophils are going to be our main driver in treatment decisions or how it affects your personal care. Basophils are another type of white blood cell known for their role in asthma. Monocytes help to clean up cells and debris. Lymphocytes actually are very important in when we're thinking about immune therapy because our immune system is made up of lymphocytes as well. And so immunotherapy can kind of enhance a part of the lymphocytes. Part of the CBC that a healthcare provider might check is a differential. Differential basically means that we're going to break down the different types of white blood cells and we're going to try and identify how many of those are in a sample. So the figure here on the bottom left is often going to be expressed as a percentage. Um, and so, oh, sorry, not on the bottom left here. The figure on the right, but the top, like the neutrophils, the lymphocytes, the monocytes, the first value is 60.2. Those are often going to be expressed as a percentage, but then we can even break it down further to see exactly how many neutrophils are part of the blood sample, and we're going to be able to get an absolute number per volume of blood. And so in this particular example, we look at the highlighted absolute neutrophil count, 4.25. That's 4.25 thousands of cells per microliter of blood. We're getting into the really nitty gritty here. That's not something that you need to know, but just to give you an example, we can add up the 4.25, the 0.01, the 1.91, and so on and so forth to total what your white blood cell count will be on your labs. Absolute neutrophil count is going to be more important to the healthcare provider making a treatment decision rather than the white blood cell. The white blood cell is all encompassing of all of the values below here. But remember what I said based on that figure, that the driver of kind of clinical significance in terms of treatment decisions will be the neutrophil count, because the neutrophil count, the neutrophils in general are the infection fighters. And so when we think about chemotherapy, we're thinking about how chemotherapy is going to kill all cells. Chemotherapy kills good cells in our body, such as our healthy neutrophils and our healthy white blood cells. And it also kills bad cells like the cancer cells, which is intended, but we can see a lot of abnormalities. And so when we are looking at somebody's blood results, blood and labs are interchangeable. Oftentimes, healthcare providers will say, your labs. So when we're looking at your labs, we're going to make a decision off of your neutrophil count, your absolute neutrophil count. Every chemotherapy is going to have a different parameter. What that means is the threshold for treatment is different for each chemotherapy. That's because based on our, data, a lot of like clinical trials and data, we know how chemotherapy can affect the bone marrow. We recall back to that first slide with the figure, the bone marrow is going to produce all of our cells. And so when all of our cells are being affected, we know exactly how each kind of chemotherapy might alter. And some may pose more risk of infection, more risk of neutropenia. Neutropenia is a reduction in the neutrophils. And in particular, that would mean that the person is at increased risk of infection. Got ahead of myself, see? So neutropenia is a decreased absolute neutrophil count. It's a common side effect of many chemotherapies. The concern is when chemotherapy has the potential to cause febrile neutropenia or fever from not enough infection fighters in the blood. We have some criteria for mild neutropenia, moderate neutropenia, and severe neutropenia. Generally speaking, severe neutropenia is going to require intervention. Um, we want to prevent infection. So oftentimes we'll use what we call preventative or prophylactic antibiotics to prevent infection. But neutropenia can increase a person's risk for any type of infection, whether that be fungal, bacterial, or viral. When a person is neutropenic, um, we can use particular supportive medications to increase the neutrophil count, but it is really important in that time for that the person be mindful of their infection exposure and limiting infection exposure if possible. In terms of supportive care, if there is great risk for febrile neutropenia, your oncologist will often prescribe a supportive medication called a growth factor to go along with your chemotherapy. Um, it can be utilized to increase the neutrophil count and to reduce the risk of infection. This is a particular brand called Neulasta, comes in both a pre-filled syringe and an on-body injector. Chemotherapy will need to be finished for 24 hours before a person gets this growth factor. Um, that's a kind of safety thing because the chemotherapy is working to kill all rapidly dividing cells, including cancer cells, and giving the Neulasta injection too early could cause worsening, essentially risk for infection. And then in this particular formulation here, the Neulasta, we don't give chemotherapy for 2 weeks after the injection. There's another type that can, if you needed chemotherapy next week, we can give a daily injection, which is similar but a little bit different. And so that can help to increase the neutrophil count, but still allow the person to get chemotherapy um, the following week, say. I want to just point out here, because this is a question that I get a lot. I also have this weird sun in my face. I'm sorry. I often get the question of, is it the same medication if I get it in pre-filled syringe or if the nurse applies the patch to my arm? It's the same medication. It does the same thing. One is not more beneficial or more effective than the other. It's also important to note that insurances are going to prefer different brands. It's all generally the same medication. We call them biosimilars. So it's all the same medication. It's called pegfilgrastim, but different brand. And so different people's insurances prefer different brands, but it's all the same medication and does the same thing, which is increase the neutrophil count. So just to give you an example about when we would use a growth factor. So we're talking about cholangiocarcinoma. The first treatment is generally gemcitabine, cisplatin, and durvalumab. And so we don't often start off with growth factor for gemcitabine, cisplatin, and durvalumab, but say a person has had their 8 cycles and they've dropped down to durvalumab maintenance. They've been on durvalumab maintenance for a little bit, and then unfortunately, disease maybe starts to act up again, have to resume gemcitabine and cisplatin. The person's had prior chemotherapy, and so their bone marrow is already a bit beaten down by chemotherapy. And so when they get gemcitabine cisplatin again, The next day that they're scheduled for treatment, day 8, they may come back and be neutropenic more than they were in the beginning. This is because the bone marrow, like I said, has had prior chemo exposure, and now the cells aren't getting replenished as quickly as if they were what we call chemo naive, or there hasn't been chemotherapy in the past. And so a healthcare provider may elect to add Neulasta to be administered 24 hours after the chemotherapy completes. Generally, we'll do that on day 9. So you get your gemcitabine cisplatin on a Monday. The next Monday, you come in for gemcitabine and cisplatin again. On that Tuesday, the person may get the Neulasta 24 hours after the second week. And moving on, so we're going to change gears a little bit and talk about the next part of the CBC. Next part of the CBC encompasses the red blood cells. The red blood cells, we have hemoglobin, and that makes up the red blood cell. And hemoglobin is an iron-rich protein that helps to carry oxygen throughout the body. So it essentially binds the oxygen, and it carries it to all our organs and tissues so that, our body can function as it's supposed to. Hematocrit is another part of the complete blood count that we measure. This is often a percentage of the red blood cells in the blood. It's oftentimes that we don't make treatment decisions based on just the hematocrit alone, because it's not as accurate as the hemoglobin would be, but it's still very useful. And so when we're looking at if a person can receive chemotherapy, hemoglobin is often the number that would be assessed. I'm talking a lot about chemotherapy because immunotherapy doesn't have many of these parameters. Immunotherapy is a whole different talk, but essentially immunotherapy is going to give your body the instructions it needs to ramp up its immune system, the body's immune system, to look for cancer cells and kill them. But it doesn't have the same effect as chemotherapy, in the sense that chemotherapy is going to kill all cells, the fast dividing cells, the good ones and the bad ones. Immunotherapy doesn't do that. So we often don't have as many parameters for immunotherapy as we do for chemotherapy. When we're mixing chemotherapy and immunotherapy, like Gemcis Durva, the parameters stand true because the chemotherapy is the driver there, right? We want to make sure that our blood counts are adequate and safe to administer chemotherapy. With that being said, if somebody comes in with a significantly, or rather a critical hemoglobin, we may have, we'll stop and think for a minute about why that might be happening, if the person was only getting immunotherapy, and likely intervene before giving the drug. So what is clinically significant during cancer treatment? Abnormally low red blood cells is anemia. And so that can definitely have implications on treatment. It can definitely cause treatment delays. And it can oftentimes require supportive care. Anemia is a common side effect, as I said, of many chemotherapies. Different oncology institutions have different parameters in terms of when to intervene, when to hold. Different oncologists also have different parameters. It's the art of medicine, as well as the science. And so oftentimes when the hemoglobin is less than 7, treatment would be held, chemotherapy would be held. There are other causes of anemia. Other causes of anemia could be blood loss. For instance, surgery. Blood loss from surgery can cause anemia. We know that with surgery, there's blood loss that in turn reduces the amount of RBCs or red blood cells. And then we can see a reduction in the hemoglobin and hematocrit. That may require intervention, may require monitoring. Um, Iron deficiency can be a cause of anemia. We will assess different blood tests or different labs, in specific the ferritin and the iron, to evaluate iron deficiency. A lot of people think that my hemoglobin is low, I need to start taking iron, but that's not always the case. It won't always be beneficial. Um, it is beneficial, however, when we do the blood tests that show us that there's a depletion of iron in the blood, and then that repletion by oral supplementation or IV can be helpful. Another type of anemia, or another cause of anemia, rather, will be nutritional deficiencies, in particular, a deficiency of folate or vitamin B12 can cause anemia. Chronic diseases such as cancer, different autoimmune conditions, chronic kidney disease, cirrhosis can cause anemia. There are certain genetic conditions, and then infections can also cause a transient or a temporary anemia as well. I think this is important to note because somebody on this webinar may have been in a situation where the healthcare provider said, your labs look abnormal, but it doesn't match. Like it doesn't match your prior value. Your hemoglobin yesterday was 10.4, but today it's saying that it's 8, and you haven't had any treatment from yesterday to today, and you haven't had any blood loss, and you're not having any concerning symptoms. And all of your other cell counts, when we check your CBC, are also um, low. It could be a false low due to blood draw technique, essentially. In a port in specific, like getting too much saline in the sample, the nurse is going to flush saline when they're prior to drawing from your port. If there's too much saline in the sample, then that's going to be a false read. And so we might check the blood sample again, to evaluate, was that false or was that a true value? Also, a person's hydration status can affect blood work. If a person is extremely dehydrated, there's less fluid. I wish I could go back to my plasma picture without totally losing my spot. But if you can remember back to that plasma, that blood sample where it separated the plasma and the blood, if a person's really, really dehydrated and there's less fluid in the sample, then it's going to look like there's many more blood cells. That can be what we call a false elevation or hemoconcentration. And when we're kind of breaking down what a person might feel like if they're anemic, from any of the causes that were just mentioned on the previous page, the symptoms somebody might feel, they could feel dizzy or lightheaded. They could feel short of breath because the hemoglobin is the oxygen carrier around the body. And if the hemoglobin is low, because that's a part of the red blood cell, and the red blood cells are low, it might make a person feel a little short of breath. So this symptom may manifest only when they're walking around and exerting themselves. It may manifest kind of while the person's at rest as well. Anemia could also cause pale skin. We call this pallor. It can cause fatigue because there's not a lot of circulating red blood cells. There's not a lot of there's not as much oxygen circulating. Can make a person really tired. Can also cause heart palpitations, what we call tachycardia. It's always important to assess for blood loss when we're considering anemia. And so, your healthcare provider, if you have a new anemia, we're trying to figure out why, they might ask you, have you had any blood in the stool? Has it been red blood or black blood? Can be an indication of bleeding from the GI tract. We ask, have you had any blood in your vomit? If you vomited, have you had any blood in your urine? These can all be helpful signs when we're assessing anemia and the causes of anemia. I always like to remind people that early reporting of symptoms can be extremely helpful in getting supportive care um, to manage anemia and to prevent treatment delays. So, if a person is several months into treatment and there's been some decrease in the hemoglobin, we're kind of monitoring that. You haven't needed any intervention, but we're still kind of monitoring. But then, you're now symptomatic, like short of breath, having more fatigue, heart palpitations, pale skin. um, you may want to call your oncologist before your next treatment so that we can check your blood work prior to coming in on the day of treatment. And then all of a sudden the hemoglobin is low, and then now we have to delay things. So I think early reporting of symptoms is extremely helpful in medical oncology, um, because it can help to get supportive care sooner rather than later, and it could cause less treatment delays. In terms of supportive care for anemia, um, like I said, I guess I didn't say this yet. Red blood cell transfusions. So we can give a red blood cell transfusion. Um, Red blood cell transfusions nowadays are extremely safe, and so the process of a blood transfusion requires you to give a blood sample. Um, we check that blood sample and what we call type and screen. So we're checking your blood type and we're screening it to match essentially what blood is in the blood bank so that we can give it to you. Um, there's an extremely low chance of infection um, nowadays. And so blood is often well tolerated and very safe. And so your healthcare provider can go through, risks versus benefits, but oftentimes red blood cell transfusion is the fastest way to increase the amount of red blood cells in the body. These next three, iron infusion, iron supplements, and a diet rich in iron, are only going to be beneficial if the blood work shows that you're actually iron deficient, which I mentioned previously. So, taking an iron infusion, or having an iron infusion, and taking an iron supplement by mouth generally will not really cause you much benefit if you're not actually iron deficient. Many of the anemias that we see are related to chemo. And the intervention for that would be a red blood cell transfusion. Could require a treatment break or a treatment hold if a person is many years into their treatment. Um, and the bone marrow has seen a lot of chemotherapy, then the treatment, you may need a brief couple week hold or a few week hold at the kind of discretion of your oncologist and with joint decision making. Um, and then there's also erythropoiesis stimulating agents. So erythropoietin is like a hormone that tells the body to produce blood cells. And so sometimes we can use these as well. I think the big question that I get oftentimes in medical oncology is, what foods can I eat to increase my red blood cells? And so if a person is iron deficient, there are foods like dark leafy greens, some citrus, sweet potatoes. Um, we meat, like red meat, that can be high in iron. Um, And so there are some dietary modifications if there is iron deficiency, the dark leafy greens and the red meat, go ahead all day long. But oftentimes, when a person is anemic because of chemotherapy, those foods don't generally help. And so, what we'll say is please eat a well balanced diet made up of proteins, carbohydrates, healthy fats, fruits, and veggies. But nothing in particular will be able to improve your anemia besides time and maybe supportive measures like red blood cell transfusion. CBC, next component will be the platelet count. And so platelets are the part of the blood that are going to help the blood clot. Um, Abnormally high platelets can pose risk to the system, causing clots, whether that be a blood clot in the leg or the lungs, or at the site of the port. Um, Abnormally low platelet count can pose risk of bleeding. I'll say that oftentimes with chemotherapy and cancer treatment, we would see abnormally low platelet count. There are certain circumstances which you could see abnormally high platelet count, but abnormally low platelet count is oftentimes the main abnormality on labs that would intervene on and would pose kind of implications to treatment. And so, and again, each chemotherapy has different parameters. We get those parameters based on our studies. And so we can treat um, FOLFOX with a different treatment parameter than GemCis. We can treat GemCis on day 8 with a different parameter than day 1. And so it's, kind of all goes in the background of your healthcare provider thinking about your labs and kind of what's safe for treatment. That's why we get your blood work before each dose. Supportive medications. So, what can we do when the platelets are low? There are some supportive medications that may be available at your cancer center. Um, One of them is called romiplastim or Nplate, which is an injection to help stimulate the bone marrow to produce platelets. Oftentimes, this is a weekly injection that we would give with chemotherapy, but also on weeks that you're not receiving chemotherapy. Um, if a person, doesn't want to travel to the oncology clinic on a weekly basis, then the healthcare provider may say, okay, we can try to give every other week or something like that. But there's risk of what we call rebound. Low platelets, rebound thrombocytopenia. And so essentially, the platelet count may go abnormally low again on a week that you're not getting that shot. So that's one supportive medication that we can use. Another supportive medication or supportive therapy would be a platelet transfusion, giving you essentially like a bag of platelets to help improve your platelet count, which is often the fastest way to improve the platelet count. However, um, platelets can sometimes be hard to come by. Unfortunately, there are no effective dietary modifications to increase the platelet count, which is another question that I get a lot. What can I do to increase the platelet count? But there's really not anything that you can eat or drink or herbal supplements that will safely increase the platelet count, or effectively, rather, too. All right, moving on to LFTs. I got to speed it up here. So LFTs, we're going to talk about the liver function test, the AST, the ALT, the ALK Phos, and the T-Billy. So AST, this is an enzyme that's not specific to the liver. So it's found in different organs like the bones, the liver, the brain, the kidneys. It's not specific. It can be increased when there is liver inflammation or injury. But it can be increased when there's another abnormality in another organ as well. The ALT, however, is specific to the liver, and so this one is a good indicator of liver injury. When the liver tests are elevated, we would be worried that there's some dysfunction in the liver or injury in the liver, something causing problem. ALK-Phos is an enzyme found in the liver, bones, the kidneys, the intestines, can be an indicator of biliary tract problems. Can also be an indicator of bone disorders. You oftentimes in cholangiocarcinoma will see an elevated ALK-Phos. Um, Elevated stable ALK-Phos, not always something to worry about. But when ALK-Phos trends up, can be a red flag for a healthcare provider that there may be a problem in the biliary tract, maybe an obstruction impending. Um, Sometimes we would get imaging to assess that. Sometimes, pending the patient's history, we would do intervention without imaging. So it just depends. Coupled with a rising ALK-Phos, you may also see a rising T-bili. T-bili, total bilirubin, is a measure of the bilirubin in the blood. Essentially, bilirubin is going to be kind of like the waste that is created when red blood cells break down and die. And oftentimes, the healthy liver just filters that out and it gets excreted through the urine and the feces. But when the liver is injured and that it's not functioning properly, that process can be disrupted. And then we can see the bilirubin be held on to, it's not excreted, and then we can see the blood tests show an elevation. So an elevated bilirubin is called hyperbilirubinemia. And so some symptoms that a person might feel would be itching, yellowing of the skin, we call jaundice. That could often start from the head down. So eyes would be the first place of jaundice often. Dark urine, pale stools. Causes of elevated bilirubin. Cancer can cause elevated bilirubin when there's, unfortunately, a lot of cancer in the liver. It can cause dysfunction. It can be caused by chemotherapy at times. Um, it can be caused by biliary obstruction or bile duct obstruction, which can be a kind of main symptom at diagnosis of cholangiocarcinoma. Can be caused by cirrhosis, infection like hepatitis, autoimmune conditions, alcoholic liver. There's really benign conditions as well that can cause elevated bilirubin um, and abnormal breakdown of blood cells. Treatment depends on the cause. So the cause is cancer, and the bilirubin is at a safe threshold, then chemotherapy would be indicated. If the if the cause is a biliary obstruction, then a stent may be indicated to improve the bilirubin. The trend of the bilirubin and the trend of the ALK-Phos and the LFTs, the AST and the ALT, are going to be really important post-intervention. So if a person has a stent placed, we want to make sure that those labs are trending down. Implications for cancer therapy. Many chemotherapies are unsafe to give with an elevated bilirubin past a certain threshold. And so each chemotherapy will have a different threshold, and you can discuss that with your oncologist. Albumin is a helpful protein that we see in the bloodstream. It helps to transfer medications and hormones throughout the body, but it's also really, really essential in keeping fluid in our blood vessels. When we have low albumin, we can have fluid leak out of our blood vessels and go into different parts of our body, like the abdomen and the legs, to cause swelling or ascites. And so albumin is also a helpful nutritional marker. Can indicate nutritional deficiencies. It can often be low in advanced cancer, can be low in cirrhosis or liver damage as well. Immunotherapy. So like I said before, immunotherapy, we don't have as many like parameters before treating with immunotherapy, but there are some labs that we're going to check on a regular basis. Like every 4 to 6 weeks, we'll probably check your thyroid function. The thyroid is one of the first kind of adverse effects from immunotherapy. And so thyroid dysfunction or abnormality can be seen. we'll see the thyroid stimulating hormone go up. If there's hypothyroid or low thyroid hormone is circulating in the body, person might feel really tired, have some weight gain, really depends because, cancer is also playing into a scenario as well. If the TSH is low and the T4 is high, you'll have hyperthyroid. Sorry, got tripped up there. I had to think about that. You'll have hyperthyroid. Person might feel palpitations. And so we will check the thyroid every 4 to 6 weeks because immunotherapy can affect these things as an autoimmune condition. And then tumor markers is kind of the last thing that I was going to go through today. CA19-9 and CEA are the two tumor markers that we're often checking in cholangiocarcinoma. And so it's important to note that tumor markers are not the whole picture. Tumor markers are a whole nother discussion here, but they're not the whole picture in terms of what the cancer is doing on the inside. But they're a helpful tool in having a healthcare professional assess, put the puzzle pieces together. They're also not totally specific to cholangiocarcinoma. So they can be falsely elevated for different reasons. Person has diarrhea, like a GI bug or something, you can see CA19-9 or CEA be elevated. Um, it can be elevated in cancer as well, and that's why we check it. And so it's only a helpful test when it was elevated at diagnosis. The CEA and the CA19 are checked and they're normal at diagnosis. They're really not a helpful test to track. Um, these tumor markers are helpful to track when they were initially elevated because the idea would be that they would hopefully go down on treatment. If they start to creep up, then we trend those results because one test is not be all end all. We often need a trend of results. If they continue to rise, your oncologist may say, maybe we should get another image. Let's see what's going on the inside. We put those puzzle pieces together with the tumor markers, the imaging, and how the patient's doing, and like clinical symptoms. An example here that I wanted to go through quickly. So this is a patient who came in for chemotherapy, and these were the labs that I saw. And so I'm going to first refer to the electrolytes. So the electrolytes are normal. That's great. That means that all of the electrolytes are balanced in the person's blood, and there's no intervention. In particular, looking at the BUN and creatinine, which are markers of the kidney function. We want to pay particular attention to those with cisplatin because they can be abnormal with cisplatin use. And so we want to pay attention to those. If a person's sodium or let's say potassium was low, we can give them some potassium. If a person's magnesium was low, we can give them some magnesium through the IV. This person's lab results for electrolytes were normal. CBC. So let's pop over to the left look at the CBC. So the white blood cell count, as you see, is elevated. Now, I know that this person had Neulasta 2 weeks ago after her chemotherapy. And so this white blood cell count, I first don't take it at face value. I'm going to ask if the person has any infection symptoms. Have they had fevers? Do they have a cough, congestion, any abnormal belly pain, anything that could be an infection? I want to make sure I'm ruling that out before I just jump to the Neulasta causing this. But in this case, the person did not have any infectious symptoms. And so her WBC count that's high is likely from Neulasta or the growth factor that we know stimulates those neutrophils and causes the elevation in white blood cell count, which in turn helps to reduce the risk of infection. Her red blood cells are low. And when we're also looking here, her hemoglobin is low. Hemoglobin is the part that carries the oxygen. The hematocrit, which is the percentage of RBCs, is low as well. And then we look at these values here, the MCH, which is essentially, the MCV first is essentially like the size of the blood cell. The MCHC is like how red is the blood cell, how much iron is in that blood cell. And so on her, I checked some iron labs, and her ferritin and her iron, um, her ferritin was low and she's iron deficient. Sometimes we see these lab values of the CBC, like the hemoglobin is 8.8, and we see some abnormalities in the size and the color of the red blood cells based on the MCV and the MCHC. And then you check the anemia labs, and the ferritin is actually high. That's not iron deficiency. And that's why your healthcare provider is going to come in to be able to assess those labs with you and explain the difference between when iron might be useful and when iron might not. And so in this particular case, she could benefit from some iron. And we're going to give that to her. A liver test. This is an example of the alk phos. I would call this alk phos stable, bouncing around a bit. 124, 131, 206, 173. It's overall stable though. Slight variations, which is where kind of that point about, when a value is greater than 100, it can mean a little bit different when the value is less than 1. This alk phos is like a plateau to me. Yes, up and down. The most recent value, 173. I would pay attention to it on subsequent labs, but it's not going to change anything today in terms of if we get an image or look for a bile duct obstruction or something. If there was a impending bile duct obstruction, then we might see the alk phos rise drastically. Alk phos 900, ALT, AST in the hundreds. T-Billy is maybe not even abnormal, but maybe it went from 0.2 to 0.9. With those other abnormalities, you might have a red flag. I like to kind of put it into perspective for my patients, like, this isn't an emergency right now, but it raises a red flag. And so that's when you pay attention to things on subsequent tests, or you evaluate in the next 2 days for repeat sample to see what's going on. Okay, so that was a lot, and I know that this kind of is a topic that's a little bit more in depth, and so I hope that I was clear enough. But yes, any questions?
Thank you, Jenna. If anyone has any questions, please enter them into the chat or the Q&A. I know a few have come in. Is it typical for a person's CEA to remain normal throughout the cancer diagnosis? Have you seen that happen as well?
I guess I would have a follow-up question in terms of, like, was the CEA normal at diagnosis? If it was normal at diagnosis, then yes, CEA can remain normal throughout cancer therapy. Some tumors just don't produce tumor markers. And so that's kind of where it becomes important. If the person doesn't produce CEA, person's tumor doesn't produce CEA, then we often don't check it again through cancer therapy, because it's not really going to benefit us in evaluating. I would say, yes, it can happen for sure.
Okay. And then with the tumor markers, if it's not relevant, like it's not high at diagnosis, but then there's metastasis, is that a good time for that to be checked again because maybe that level has now changed?
Yeah, potentially. If there's a decent period of time between, the person's, say, surgery, originally at diagnosis, CA 19-9 was not elevated. They had surgery. They had their chemo, they had surgery, and then unfortunately come back, a year later and have a metastasis, then yeah, I would say CA19-9 could definitely be checked again, or CEA, both. Mhm.
Okay. And then in your experience, are there any other indicators that could be checked if the CA19-9 isn't one that's showing up? Is there something else that the medical team should look at?
So the two main tumor markers in cholangiocarcinoma that would be produced by the tumors would be CA19-9 and CEA. So if CEA is not elevated and the healthcare provider has not checked CA19-9, I would say a CA19-9 could be checked, and vice versa as well. But we don't, as of right now, have many more tumor markers to be able to track cancer. But, there's always new research, and hopefully someday soon.
Perfect. Um, After completing chemo and chemoradiation treatments, how long would you expect the white blood cell and red blood cell values to rebound and appear more normal?
Yeah, I mean, it can take months. The average lifespan of a red blood cell is actually 90 days. So that's 3 months. And so the bone marrow is constantly producing cells, but it can take years sometimes to get back to like a totally normal, depending on where the person was originally after treatment. Um, but it can take several months for sure.
And then can you address AFP as a tumor marker?
Yeah, AFP is oftentimes helpful when AFP is alpha fetoprotein. It's often helpful when we're trying to figure out if cholangiocarcinoma may be a cholangiocarcinoma or a hepatocellular carcinoma. Um, AFP is not often a tumor marker that my practice checks routinely with a known cholangiocarcinoma diagnosis. We more follow AFP with liver cancer, like hepatocellular carcinoma. It can be a helpful tool, I guess, when there's like a mixed scenario, like HCC and cholangiocarcinoma. If your pathology showed that, then it may be beneficial. But if it was an intrahepatic cholangiocarcinoma with like kind of the routine features of a cholangiocarcinoma, my practice in particular doesn't often check AFP right off the bat.
Okay, perfect. And I know you had mentioned Neulasta. Can you explain why maybe someone might get Neulasta over Neupogen? We've heard both with patients.
Yeah. So Neulasta is the lasting one, and Neupogen is the one time, is the short acting. So Neulasta lasts. It's just the way that the drug is kind of encapsulated, and it allows a kind of extended release over a period of 2 weeks. And so it's a one-time injection. Neulasta lasts. It's a one-time injection that the person will get 24 hours. Sorry, 24 hours after chemotherapy. Uh, 24 hours after chemotherapy. Neupogen is a shorter acting formulation in which a person would need several days of the injection to be able to stimulate the blood cell count, like 5 days or so. But we use both. It just depends on if the person needs chemotherapy sooner than 2 weeks from the day of injection.
Okay, perfect. I don't, oh wait, let me see. A couple more questions. Um, could you specify differences in the parameters between chemo and immunotherapy?
Yeah. So, like I said, immunotherapy has a lot less of a restriction. There are certain things that we would we would definitely check. We're always going to check a CBC. We're always going to check electrolytes. We're always going to check thyroid function routinely for immunotherapy. But like oftentimes, neutropenia will not be caused by immunotherapy. Low platelet counts will not be caused by immunotherapy. Anemia will not be caused by immunotherapy. Can still hold up treatment because we have to figure out why those things are happening if you're just getting immunotherapy alone. Um, but oftentimes, I'll say the cause of the abnormalities seen on blood work are not from the immunotherapy part, they're from the chemo part.
Okay, perfect. I know someone is asking about immunotherapy for someone who is NED, and I don't know if you're able to
Um,
respond to that type of a question.
I mean, I, it's really, it depends on a particular situation, on if the patient had surgery or no surgery or where they are in their course. That's a super particular question. I'm sorry, I can't answer that.
No, that's fine. Thank you. And I think those are all the questions that we have. I know we're a little over 3. I appreciate your presentation. I think it was very thorough and informative. So thank you so very much.
And I'll just
If
ask that you would provide this to the webinar participants. I think this is a great reference for everyone. The NCCN guidelines are the Bible of oncology, and so they produce a patient version as well. And so I think that this particular anemia neutropenia guideline is super helpful and easy for patients to understand. So I listed the link there.
yes, perfect. We will include it in the recording of the webinar, the recording. So it will be there for everyone to have access to. Thank you, Jenna. Again, we appreciate your time and the information.
Thank you.